in the esophagus. Too deep ends up in the right main stem. All right? This should be relatively close. So I would expect an 8.0 ET tube to be roughly 23, 24, 25 centimeters, right there around that 24 mark. Too shallow is most likely in the esophagus. Too deep is most likely in the right main stem. So if I haven't intubated them, do they have a gag reflex? Do I need to intubate them? If I've intubated them, and we talked about this earlier, and you start seeing this on your capnography, and you get the clap, we need to turn around and what? Sedate them. So instead of extubating them, we might have to go ahead and give them some Versed to keep them down. The problem with extubation in the field is they're at risk for aspiration. The other problem is if I extubate them and it swells their vocal cords and they get some laryngeal edema, if they crash again and I go in to re-intubate them, it's going to end up making it difficult to get that tube in. All right? So those are some of the things I'm going to do. So I'm going to recheck the airway. If I have a King tube, ET tube, is it still working? If I didn't intubate them yet, do they need it? All right? That will also help me rule out the number one cause of PVCs, which is hypoxia. If the blood pressure is greater than 90, we're going to do a 12 lead, consider cath lab, and consider working on our H's and our T's. Now, they may not need to go to the cath lab. We don't know though. That's why we do a what? A 12 lead. We don't know why they died. They could have had a massive heart attack. We do a 12 lead. Now that we got them back, we see ST elevation, take them to the cath lab. If the 12 lead's normal, consider with our H's, keep going through our H's and T's to see if we can figure out what actually ended up causing them to die. All right? If the blood pressure is less than 90, we're going to do a fluid challenge. If the fluid challenge doesn't work, then we're going to hang some sort of pressor. We could either hang dopamine, which is probably what the registry is going to use, at 2 to 20 mics per kilo per minute. We started at 5 to 10 mics. Or in Biotel, we would hang what? Levophed at 8 to 12 mics a minute is the shortcut for Levophed. So that's only if this person's blood pressure's low. I have to start working on the blood pressure. Somewhere through here, if I get time, I'll do a 12 lead. But that 12 lead is not going to make them perfuse like what fluids and a pressor would. All right, so it's going to kind of depend on how many personnel I have on the scene. So Ross, good BP, 12 lead, consider cath lab, keep working on my H's and T's. Ross, bad blood pressure, fluid challenge, pressors, 12 lead when I can. If the 12 lead shows ST elevation and continuous leads, I'll activate the cath lab. I'm still going to have to address the perfusion issue with fluid challenge and hanging a pressor, either dopamine or Levophed. All right? Does that kind of make sense? That's our down and dirty Ross. Recheck airway. What's my vital signs? Pressure's good, 12 lead, H's and T's. Pressure's bad, try to get the pressure up. Get a 12 lead when you can.
For that Levophed, or you can just kind of shoot in the middle? Like dopamine, you said start 5 to 10. Levophed, would you do like 10 to 12? Just start at 12?
Well, it's actually 8 to 12 mics a minute is your initial dose. Small person 8, big person 12, medium person 10.
Okay.
That's kind of the dosage range. Our actual protocol has a specific number, but we're not going to get there yet. Don't worry about the Biotel stuff till you have a red patch. Because without a red patch, you can't do anything Biotel. Fair enough?
Fair enough.
We can add that later.
Are they going to prefer one or the other?
No, they're going to give you the range.
Okay.
They'll give you one or the other. They're not going to give you both. They're going to give you one or the other. They're not going to give you both. All right? What they would do is say, here would be an example of that. They say, you have 56-year-old male V-fib. All right? He now has a pulse, and they'll show you a rhythm strip above, and he is intubated. All right? And then they say BP is 80 over 40. And then it will say, what is most likely to increase his blood pressure? And they may even go patient in VFib, shocked times 3, given epi and amiodarone. He now has a pulse. He's intubated. They're telling me he has a pulse. He's intubated, which is my recheck airway. Still good. Blood pressure is 80 over 40. What is most likely to increase blood pressure? And they may go amiodarone drip, lidocaine drip, dopamine drip, or fluid challenge. Most likely to increase blood pressure in ROSC.
Dopamine drip.
Remember we talked about that earlier, most likely. Or they could do away with the dopamine and go atropine and go, what should you consider to increase blood pressure? Well, I don't have dopamine or Levophed listed, so now it's a fluid challenge. They're not typically going to list both, all right? Because they're both acceptable. It depends on what, where you work, all right? Tracking? All right, here we go. So how do I do drug counts? Remember, 1 equals 1,000. So 1 gram equals 1,000 milligrams. 1 milligram equals 1,000 micrograms. Every time I put a drug in an IV bag, unless they tell me otherwise, I am supposed to use the 60 drop set. 60 drops equals 1 milliliter of fluid. So every 60 drops that comes out of this IV bag will have a milliliter of fluid. So 30 drops would only be half a mil then. 15 drops would be 1/4 of a mil. 45 drops would be 3/4 of a mil. That's how much fluid's coming out. All 60 drops, a whole milliliter of fluid. If I only gave 30 drops in a minute, you would only got half a mil. Does that kind of make sense? That's what that's telling me. This will never change unless they tell you otherwise. All right? So what I need to do is I need to take my drug, add 3 zeros to it. Oops. And divide by IV bag. That answer is going to go on top of the clock. So here's an example. I say drug X is supplied 2 grams into 500 mils. You have 30 drops per minute. How much drug is given? Forget all this crap. Can you give 2 away to 500 people?
No.
So what do we add to the 2?
3 zeros.
So add 3 zeros. Grams becomes milligrams, correct? Divide by your IV bag. That's 4 milligrams per mil. So every 60 drops that comes out contains how much drug? 4. What's half of 4?
2.
Half of 2.
1.
1 plus 2 is 3. So if I'm given 30 drops a minute, how much drug is that?
2.
2 milligrams of what? A minute. That's how much drug I'm given. 2 milligrams a minute. Don't make this stuff hard. Take the drug, add 3 zeros, divide it by the IV bag, and that answer goes on top of the clock. What if I told you,
Will there be drug count on there?
yes, 1 to 3. They're going to ask you 1, you get it wrong, they're going to start peppering you. Way it works. It's like your football coach. We're going to run it until you get it right. The more you mess it up, we're going to keep hammering you. And then once you get it right, we'll move on. It's kind of the way that test works. All right? So, what if I said 2 grams into 500, give 3 milligrams a minute? How many drops a minute is that?
45.
Well, same math. Add 3 zeros, divide by the bag. Last time I gave you 30 drops and wanted to know how much drug that was. This time I'm telling you 3 milligrams a minute, and I want to know how many drops that is. There will be a calculator on the computer screen when you take your register. It will be in the top right-hand corner. You drag your mouse over it, and it will be a basic calculator. All right? This should be on your dry erase board. Add 3 zeros, divide by the IV bag. Let me clean it up a little bit. All right? The answer was 45. That's correct. So, add 3 zeros, divide by IV bag equals question mark on top of 60. This should never change unless they're jacking with you. And we'll get there in a minute. So I want you to do 400 milligrams drug X into 250 mils. Give 5 mics per kilogram per minute. Patient weighs 80 kilograms. How many drops per minute is that? Forget all this wording. What do we add to our 400?
3 zeros.
3 zeros. So 400 becomes 400,000. Milligrams becomes what? Micrograms. Divide by your IV bag. That's 1,600 mics per mil. Where's 1,600 go? What's half of 1,600?
800.
Half of 8. 400 plus 800 is 1,200. So now my concentration is done. Now I have to take 5 mics times their weight. So 5 times 80 is what?
400.
400. Where is my 400 at on my clock?
15.
So how many drops a minute is that?
15.
15. You just did dopamine. Don't make this hard. Add 3 zeros, divide by the bag. The answer goes on top of the clock. All right, let's do another one.
All right.
Drug X. It's 4 milligrams into 250 mils. Give 8 mics per minute. How many drops per minute? Well, what do I add to my 4?
3 zeros.
Milligrams becomes what?
Micrograms.
Divide by your IV bag. That's 16 mics per mil. Where's your 16 go?
On top.
Okay, what's half of 16?
8.
Half of 8.
4.
4 plus 8 is 12. They want you to give 8 mics a minute. How many drops a minute is that?
30 drops.
What? Okay,
I'm gonna add this to you. Use a 20 drop set. Or I could do this. It's a jacked up clock. 20 drop set means every 20 drops that comes out is how much fluid? 1 mil. So instead of having 60, I have 20. What's half of 20?
10.
Half of 10.
5.
5 plus 10 is 15. I just got a jacked up clock. Yeah. I just have a jacked up clock. What if they wanted this to be a 30 drop set? Okay.
And the only reason you're changing that is because they're telling you, hey, you
Correct.
drop
If they don't tell you the drop set, we are going to default to 60.
every time.
99% of the time, it's going to be a 60 drop set. Unless they wanted to jack with you for some reason. All right? I think the few times that's occurred, it's a pilot question, but it's no big deal. I just got a fucked up clock. Instead of being 60, I put 20. You got 100 drop set. Okay. 100 up top, half a 100's a 50. It's just a messed up clock. Don't overthink it.
So you're
Right.
just changing the clock to what the drip set they give you.
Correct, because this drip set equals how many drops per minute. A 60 drop set means every 60 drops is 1 mil.
I get it.
A 15
Thanks.
drop set means every 15 drops is a mil. A 10 drop set means every 10 drops is a mil. That's all we're doing. We're just changing the drops in the drop state, yes.
Will they ever change the bag size to 50%?
Sure. It doesn't matter. Let's do 400 milligrams drug X into a 500 ml bag. Give 1,200 mics per minute. How many drops per minute is that? Okay?
Eight.
Milligrams becomes mics, which is good, because that's what the answer is in. Divided by 500, that's 800 mics per mil. Draw your clock. Where's 800 go?
Top.
What's half of 800?
400.
Half of 400?
200. 600.
But they want 1,200, so what do? I go all the way around the clock. That gives me 60 drops and 800. I need another 400 to get to 12.
Right.
So I need another 30 drops.
So it's 90 minutes.
90 drops a minute.
Fucking A.
Or what if I wanted 300?
In between.
It's halfway between 15 and 30. What's halfway between 15 and 30? 22 and a half. Because halfway between 0 and 15, this would be 100. This would be 300. This would be 500. This would be 700.
They wouldn't do that, would they?
It's just math.
No, no.
This is 7.5, 22 and a half. Because every 100 is 7.5 drops. It's just, don't make this more difficult. Y'all see the word drugs and you freak. All we're doing is taking this, adding 3 zeros, and dividing by how big that bag is, and putting it on the clock. I'm going to give you one more. To me, this is the easiest drug calc, but it's probably going to kick your butt.
Oh, fuck. How's it? Why am I even asking?
All right, patient in severe anaphylaxis, medical control, orders a drug at a 16-to-1 ratio, give 4 mics a minute.
16.
Let me ask you over there. When we do our clock, the number on top of the clock is per 1 milliliter, correct? So this is 1,600 mics of drug for every 1 mil.
So cut that by
If they give you a 16-to-1 ratio, that means that you have 16 parts drug to 1 milliliter fluid. What's half of 16?
8.
Half of 8. 4 plus 8 is 12. Doc told you to give 4 mics a minute. How many drops a minute is that?
15.
So if you have a drug :1, they've already done all the math for you. That first number goes on top of the clock. This is telling me 16 mics per mil. How do I know it's 16 mics per mil? Because that's what they want the answer in, and they didn't tell me divide it by anything. What if I wanted to make it? They've already done the math. Have you guys looked when you were in the lab at the hospital or on your ambulance at a pre-mixed bag of lidocaine or dopamine? When you look at the red letters on lidocaine, it says 4 milligrams per mil. That means that the concentration is 4 milligrams for every milliliter of fluid, or 4 milligrams for every 60 drops. If I told you dopamine is 1,600 to 1, what number goes on top of the clock then?
1,600.
What if I told you an epi drip is 16 to 1 concentration, which is what this is, by the way. You
Right.
mix the epi drip to give to severe anaphylaxis, which we talked about this morning in severe cases. If they give you a number :1 that first number goes on top of the clock. All right? So if they go, so basically we got two formulas related to drugs. We got this one where they gave us a drug and we had to have 3 zeros. If they go drug X is :1, then X goes on top of the clock. Easy enough? You have a drug that is 800 to 1. Where's the 800 go? And then we fill out the rest of the clock. You have a drug that's 12 to 1. 12 goes on top of the clock. You have a drug that's 1 to 1. 1 goes on top of the clock. Don't make the shit hard. If they give you the drug in a bag, add 3 zeros, divide by the bag. If they give you a concentration, :1, that concentration goes on top of the clock. This should be on your dry erase board. Another potential formula they could give you. All right?
Sir, quick question. The added 3 zeros, you only do that if it's on micro, like, doesn't matter what unit is on?
I only do it when I'm putting a drug and dividing it by the IV bag. For example, if I gave you 1,000 or 1 gram, I gave you 1 gram of lidocaine.
Right, that's 1,000.
Once I put it in here, it's got to be diluted.
Right.
So the only way I can dilute it is to change the units. Kind of like if I gave you $1 and I said, here's $1, you got 5 kids. How are you going to change this dollar to where you can divide it evenly amongst your kids?
Right.
You would start looking at, well, I got 5 kids. I'll change it into nickels or dimes to make it equal. That's all we're doing. We're taking that 1 and cutting it into 1,000 pieces to where we can now have a concentration of it. So it doesn't matter what it is. If they tell you a drug into an IV bag,
Yeah.
you're going to add 3 zeros. Grams becomes milligrams. So if I said 1 gram, it's 1,000 milligrams. If I told you had 1 milligram of drug, it becomes 1,000 micrograms. We're cutting it into 1,000
Okay.
pieces to where we can give it away equally.
Okay. All right, cool. Yeah, I just didn't know.
All right? What if I asked you this? Give 200 milligrams Carnival over 20 minutes using a 250 milliliter bag. All right, they're not asking you to do anything with this other than give 250 cc's of fluid over how long? Yeah, they're not asking you to take the drug and cut it in small pieces. They're going, hey, I want you to drink all of this in 20 minutes. I don't care how much drug is in it. I don't care how much is in it. I just need to give this whole bag to you in 20 minutes. This bag just happens to have some drug in it. I'm not giving you a drug, telling you to divide it by the bag and then figure out how much is in each drop coming out. All I'm saying is, here's a bag of fluid that happens to have a little drug. Give it all in 20 minutes. The formula for this is fluid times drop set divided by time in minutes. Well, if there's a drug in an IV bag, what type of drop set is it?
16.
How much fluid is there present? 250. Don't worry about the drug. I don't want you to give like 5 milligrams a minute. I want you to give the whole damn bag. So in this case, it's my fluid is 250 mils times 60 divided by 20 minutes. So it'd be 250 times 60 divided by 20. So that's what? 1,500 divided by, what, 75 drops a minute? 750 drops a minute? That's why you got a calculator on the test. 250 times 60 divided by 20. What is it? 750. Don't get bogged down because they put a drug in there. That's the same as me saying, you have 250 milliliters of fluid using a 60 drop set over 20 minutes. That's all we did. Take this IV bag and run it in over this amount of time in minutes using this type of drop set. That's all it was. How do I know what drop set to use? If there's a drug in an IV bag, it's always a what? If it's an IO, regardless of the patient's age, it's a what? 10. If it's an IV in somebody over the age of 12, 10. If it's a 1-year-old, 60. IVs in kids is a 60. IVs in adults is a 10. Every IO, regardless of age, is a 10 drop set. So what if they told you this? What if I said, I'll hold off on that. I'll do that one later. Because I want to cover that in PDs. All right. What if I said this? You have a 56-year-old male, full arrest, with an IO. Give 500 milliliters of fluid over 10 minutes. So they didn't give you the drop set, but it's an adult and an IO, so we know it's what? So basically I would go fluid, 500, times your drop set, divided by 10 minutes. So 500 times 10 divided by 10 equals 500 drops per minute. Or I could make this, I don't know, let's make it something random. 25 minutes. Well, now I take 5,000 divided by 25, which would be what? 200 drops a minute. All it is basically plugging numbers into the formula. Yes, sir.
You said on the all IO, the 10 drop sets.
Correct.
What did you say?
So all IOs, regardless of age, whether it's a 6-day-old baby or a 100-year adult, all IOs go on a 10 drop set. All adult IVs go on a 10 drop set. Pediatric IVs go on a 60 drop set. And anytime I put a drug in the IV bag, that IV bag with the drug needs to run through a 60 drop set. All right? This is just basically what? Formulas. How are you going to remember formulas an hour into the test under stress?
Dry erase board.
You better have your dry erase board. Because I promise you, if they throw up that 200 milligrams of Cardivol in a 250 ml bag over 20 minutes, come May 5th, you ain't going to remember that. But if you have it written down on your form, how easy is that? If you have that stuff written on your dry erase board, it makes that math and number stuff so much easier. And basically, I'm looking at three things. Drug in the IV bag, and they want a specific amount per drop. That's add 3 zeros, divide by bag, put on top of the clock. If they give me the concentration colon, that's the amount of drug on top of the clock. If they tell me run this amount of fluid over so long, then it's fluid times your drop set divided by time. If they don't give you a drop set and it's an IO, it's 10. If they tell you and it's adult in an IV, it's 10. If they tell you there's a drug in the bag, it's a
60.
If they say you just started an IV on an 8-year-old, 60.
Wait, what?
What age do they go from the 60 drop to the 10 drop?
12.
Oh, yeah, okay.
And the pediatrics is really kind of a pain. For cardiac arrest purposes, if they have boobs, pubes, bumps, and lumps, in other words, they got breasts and they got balls, or they got facial hair, armpit hair, then regardless of age, they get worked as an adult. So if you have a 10-year-old with a beard, you're going to work him as an adult. If you have a 10-year-old with no facial hair, no signs of puberty, they're going to get worked as a kid. If you have a medical problem and they're not cardiac arrest, we're going to treat them all the way up till age 18 as a minor until they're over age 18 and they can give consent. The Vitel rules are different from all of that. Because Vitel considers somebody that hasn't reached their 12th birthday yet to be a pediatric. But if they've reached their 12th birthday, then you can go to like Parkland, but not Medical Center of Plano for trauma. But don't worry about that shit. Signs of puberty, cardiac arrest, adult. Under the age of 18, they can't give consent. We'll treat them as a minor from a psychological or consent purpose. But from 12 to 18, they should be big enough that the drugs and everything are equal to that of an adult from age 12 up. All right? And if y'all stop and think about it, man, every kid out there now is different. At 11 and 12 years old, I was 6'1", 203. I graduated high school at 6'1", 208. Never graduated. Never grew again. My little brother, sophomore year, was 5'2". His sophomore year, he graduated and reported to college football at 6'4", 290. I'm the run of my family. But in 7th grade, I was the biggest kid around. And then by my senior year, I was just average. So, I mean, that's what you have to look at. One of the kids yesterday said they ran an 11-year-old that was 6'5" and 200 and something pounds.
Jesus.
We're not going to work him as a kid. Get your ass on the cop, kid. Ain't going to happen. So, and that's why we now have to use a little bit of judgment in there from a legal consent and psychological thing under the age of 18. But y'all seen it. There's some 10-year-olds out there that are as big as some adults. There's some 10-year-olds out there that sure are going, man, you look 2. There was a kid in here yesterday, one of the rookies that, man, he looks 12. I didn't say that. But so that's why it becomes a little bit more vague. All right, roughly over the age of 12, we'll do an IV and they'll start getting adult dosages as long as their weight will handle it.
That middle formula, is that how many drops we're going to get per minute?
That's correct. So this will equal drops per minute. Yes, sir. Right? We good on drug counts? Don't make it hard. You're going to see 1 to 3. They're going to give you a drug into an IV bag, or they're going to give you a concentration. All right? Practice it. Practice it. Practice
So
it.
these 3 things that you showed us, they should cover everything, right?
They cover everything.
Okay.
You just got to pick the right one. All right? We good on Ross, and we good on drug counts. All right. Now, let's look at MIs versus angina before we move into 12 leads. In an MI, why are they Kuhlfeld clammy? Why do they have nausea and vomiting? Why do they have shortness of breath? And why do they have pain?
Poor perfusion.
Okay, which means what?
Like blood flow to the heart.
Which means what? Not enough oxygen. Because they have a blockage, because they can't transport blood, they can't get enough oxygen and sugar to the cardiac tissue.
Oh, damn it.
Everybody in this room has probably had a Charlie horse at one point in their life. A leg cramp. A leg cramp is a tightening, squeezing sensation that if it was in your calf, it locked your muscle up, felt like somebody's taking their fist and pushing on it, and it radiated up the back of the leg, correct? Is cardiac chest pain not a squeezing, tightening sensation? Somebody putting the fist in the center of the chest and it radiates up? It's because they're the same damn thing. You got a Charlie horse because your muscle had to work and it didn't get enough oxygen and sugar because you were working it harder than you could get oxygen to it. So it went from aerobic to anaerobic, which produced a lot of lactic and frumic acid, which broke down to carbonic acid, which broke down to water and carbon dioxide. You sweated off the water, you breathed off the carbon dioxide, and you threw up the stomach acid if you built up too much acid during that workout. Make sense? Well, what do we have here? We have a heart that's beating and a muscle that's working, and it's having to beat 60 to 100 times a minute, regardless of the ability to deliver oxygen and sugar. So that tissue goes from aerobic to anaerobic, starts producing a large amount of lactic and rubic acid, creates carbonic acid, breaks down into the water that they're sweating off, which is why they're cool, pale, clammy. The CO2 they're breathing off, which is why, despite clear breath sounds, despite a pulse ox of 99 to 100%, they feel like they can't breathe because they have all the oxygen in the world, but it's not being delivered to what? The heart. So the heart is hypoxic despite having adequate oxygen. Well, if we don't have any oxygen, the body's an idiot. If we don't have any oxygen, we must have lost blood. If we must have lost blood, what nervous system kicks in? Sympathetic. And we release what drug?
Epinephrine.
Epi, and the alpha effects of epi are going to steal the blood from the extremities back to the core. So when we start shunting all that blood, our extremities become cool, pale, and diaphoretic. The more severe the heart attack, the more the release of epi, the more diaphoretic they become. So their entire extremities are now becoming acidotic. They can't sweat or breathe off enough of the acid. So in order to eliminate the acid, they will start to vomit. When you vomit, what lies between your esophagus and your carotid arteries? Your vagus nerve. What's that going to do to the heart rate when they start to vomit?
Slow it down.
Slow it down. Having a slower than a normal heart rate in a heart attack is good. Why?
That's going to push a lot of pressure.
It doesn't need as much oxygen. If your car's not running good, are you going to drive at 120 miles an hour? Are you going to slow it down and limp it to the mechanic? So by vomiting, they stimulate that vagus nerve to drop the heart rate a little bit to where the oxygen doesn't need as much oxygen, their heart doesn't need as much oxygen. However, the problem is if they're vomiting, they're at risk for aspiration and choking on it. That's why they get those signs and symptoms. Our goal is to move the acid out and oxygen and blood in. The only way to move acid out and more blood in is to make the pipes what? Bigger. Which is why nitro is the drug of choice for an MI or angina. If I give them oxygen and they don't need it, what is that going to do to them? It's going to make them vasoconstrict. Well, they're already vasoconstricted because of acid and hypoxia. Because they have cholesterol built up in there. So high flow oxygen will actually make them vasoconstrict. So the treatment order for cardiac patients is ONA.
That's for oxygen nitro.
Not MONA. MONA is not the correct order. We had one of our students the other day missed a bunch of questions because he thought, well, I start with morphine. That's the first letter of MONA. I understand where he came from. Now, I'm only going to consider oxygen. What does consider mean?
Do they need
You're not
it?
getting-
Do they need it or not? If the pulse ox is 96%, they don't need any oxygen. If they're having a heart attack and their pulse ox is 90%, they need some supplemental oxygen. My goal with oxygen in an MI is to get them from the low 90s or upper 80s to the mid 90s. My goal is not to get them to 100%. Because I don't know when they go from 100% to 2, 3, 4, 500 and they vasoconstrict. So my goal is to give them enough oxygen to where they're not hypoxic, but they're not 100%. So let's say they're 92%. Put them on a what?
Nasal cannula.
Put them on cannula, 2 to 4 liters. If they're 100% on room air, that's fine. Don't put a pillow over their face and try and lower the pulse off. That's fine if it's there on their own. Okay? So, consider oxygen. Do they need it or not? If it's below 94%, probably ought to give them some. 96-ish, we're fine. 94 to 96, a little gray. Depends on what they look like. All right? Aspirin, ASA. We are going to give 2 to 4 baby aspirin. That is textbook. 162 to 324 milligrams of aspirin. Viatel says we'll give them 324. It's actually 324 and some change.
Yeah.
One adult aspirin is 325 milligrams. For baby aspirin is 324 and some change. So on the registry, they may say 4 baby aspirin, or they may say 324 milligrams of baby aspirin, or they may say 1 adult aspirin at 325. They're all close enough. Okay? The problem with an adult aspirin, and the reason why we don't typically give it in the field, is because they're nauseated. And if we give them water bouncing down the road to take the adult aspirin instead of chewing it up, they may end up vomiting it back up. All right? Most of the time, though, depending, the cardiologist will make them take a whole aspirin or a baby aspirin a day. It just kind of depends. So I don't want you to get bogged down. Oh, shit, I'm supposed to give 4 baby aspirin, and all they have listed is 325 milligrams. 4 baby aspirin is basically 325, okay? Don't get so tunnel vision that if it's not the exact thing, it blows your mind and vapor locks you. 4 baby aspirin or 1 adult aspirin, 324 to 325, I'm happy with those answers. If they give you a dose of 162 to 324, I'll take it. 2 to 4 baby aspirin is actually what the ACLS says. It's kind of up to you and your doc. All right? Nitro. Nitro is 0.3 to 0.4 milligrams sublingual. It depends on who you bought it from and whether it's tablets or spray. Don't get caught up on it. Oh, they always told me 0.4 and it listed 0.3. Okay. It's 0.3 to 0.4 depending on what type of spray or pills you have. If I do aspirin, I do nitro, and they're still having pain, I'll consider morphine. Morphine is 2 to 4 milligrams, 2 to 5 milligrams. All right? I'm going to keep giving nitro and morphine as long as their blood pressure tolerates it. Now, we have to know the difference between have to and should. All right? Have to and should. You have to have an IV in 12 lead prior to the administration of nitro. No, you do not. You do not have to. Raise your hand in here if you were not an EMT. Raise your hand in here if you did not take the EMT registry. Raise your hand in here if you took the state test in. Raise your hand if nitro was not an EMT drug. So you mean to tell me I would let you assist with nitro as an EMT, but you couldn't do an IV and you couldn't do 12 leads, but now that you're a paramedic, oh by God, you can't give it unless you have an IV or 12 lead. That's not true. You do not have to have an IV or a 12 lead prior to the administration of nitro. If that was the case, no EMT or no patient at home could ever take nitro. Should you try to have an IV prior to the administration of nitro?
Yes.
Should you try to have a 12 lead?
Yes.
Yee.
Does shit go wrong and you can't get an IV?
Yee.
Did you still give it?
Yeah.
Oh, you just broke your own rule. How many times did you run 12 lead and it says poor data quality overridden? You know what that makes that 12 lead? Non-diagnostic. Useless. But you still gave nitro, didn't you? You gave nitro based on the fact their pressure was above 90, based on the fact that they didn't have any contraindications. You still gave the nitro. So you see the difference between have to means you can never, ever, ever give nitro without an IV or 12 lead versus I should try to get a 12 lead and an IV prior to the administration nitro. Does that make sense? Have to? No. Should you try? Yes. The bottom line with that is justify your decisions. Dave. I see you gave this guy nitro and you didn't have an IV. You're right, Doc. Blood pressure was in the 180s. I did a 12 lead. The heart attack looked like it was on the left side in the lateral leads. We all stuck him. Couldn't get an IV, but his pressure was so high, I wasn't concerned with it bottoming out his pressure. Plus, I knew it was a lateral wall MI. That's not going to drop the pressure. Medical director is probably going to go, okay, because I gave him a what?
Explanation.
An explanation and a thought process. It wasn't just, versus I get an IV, blood pressure is 92/60, and I choose not to go ahead and give the guy nitro, and I give him 200 of fluid instead. Doc calls and goes, Donovan, what are you doing? Why did you give this guy 200 of fluid instead of giving him nitro? Well, his blood pressure was a little low. Yeah, but registry says any pressure above 90, you can give nitro. That's true, Doc, but when I did a 12 lead, I saw inferior elevation. I moved E4R over, and it looked like it was the right ventricle, so I went ahead and gave fluid instead of nitro, and his pain went away. He may not be happy with me, but I at least gave him a what? Explanation. And so that's why it's best to do a 12 lead and try to get IV, but it's not always possible.
What happens if you don't have a 12 lead and they do have a right-sided or inferior? What do they?
You mean like what we did for 30 years prior to the invention of 12 leads?
So nothing happens to them that you can see. Right?
Most of the time, it will bottom their pressure out if they were truly preload dependent. Which a preload dependent MI needs fluids. So in the old days, if we gave them a nitro and it bottomed out, put their feet up and give them a fluid bolus. What does the right-sided MI need anyways? Fluid bolus. We're just getting there a little quicker than we wanted to. Which, and when we start in 12 leads here in a minute, it kind of makes sense. Early in my career, I never could figure out. I was like, okay, why do we run on this one patient? They took one nitro and their pressure's 70 when we get there. Or I got that one patient back at the ambulance, pressure's in the 140s, I give them a nitro and they bottom out. But yet this next patient, I can give them 4, 5, 6 nitro and it never touches their pressure. That makes no sense to me. When we started adding 12 leads and stuff, and you start thinking about, okay, well, the right side is preload dependent, the left side kicks the blood out, this right side has to have pressure coming into it if that right ventricle's damaged. And so it started making sense once we added 12 leads, and we're not going to go back in time. But worst case scenario, they bottom the pressure out, Trendelenburg, fluid bolus, and that's what they need anyways. And when we dissect the heart here in a minute, it will make a little bit more sense. Do we understand the difference between have to and best or should? You have to wear your gear on every fire. Correct?
Yes, sir.
That's the rule. You should wear your gear on every automatic alarm. Doesn't happen though, does it? It's just kind of one of those things. So, have to means you can't do it without it at all. All right? Should means I'm going to do my best effort to try. And everybody in here, we have those patients, you just can't get an IV to save your life. If their pressure's high enough and there's no contraindications, we can give them nitro. I wouldn't do it if it's down in the low hundreds, but they're 170, 180, they can tolerate the nitro. They're 92, I'm not rolling that dice without an IV. And I mean 92 systolic. All right? And that's what you have to understand. And that's why there's a little bit of wiggle room in there. So, oxygen, aspirin, nitromorphine, you should get a 12 lead as soon as possible. You should get an IV as soon as feasible. But you don't have to. It's best if you do.
What was the other contraindication you said? Pressure less than 90 and what else?
Viagra, ED drugs. Everybody knows the ED drug, they'll list it as this. You took it so you could slide in a field. That's why it's called sildenafil. It's not, but it makes sense. All right? That's why you took it. You want me to draw you a picture?
No.
All right? Yes.
You know the time frame, like say it took
24 to 48 hours.
24
Yep. 24 to 48 hours, and usually they'll put something like, patient was being intimate with his wife, sudden onset chest pain, shortness of breath. Well, if he's being intimate, what might he just taken? And that's what they'll put in those test questions. All right, they're not typically going to go, patient took Viagra 27 hours ago. They're not typically, like I said, they're there for the meat and potatoes. Do you know if I've taken nitro, avoid, or taken Viagra, avoid nitro? That's what they're not going to be like 24 hours and 1 minute. So quit stressing and worrying about that stupid little stuff like that. All right? Patient took Viagra and is being intimate with his wife. All right? Okay, well, I can't give nitro now. They're not going to go, patient had Viagra 7 days ago. So just take it at face value, meat and potatoes, move forward.
It's a
All right.
patient, he's still fucking.
I'll tell you what, they don't always smile. I read my baseball coach who had a V-fib seizure and he wasn't smiling.
Oh, fuck.
He's deader than a hammer.
Ah,
All right,
yeah, hard dick.
so what's the difference between an MI and angina?
Angina is like a.
Relieved by
Angina is
rest.
temporary, but it's not really temporary, it's a chronic condition. But it occurs temporary.
Relieved by
So
nitro.
here's what you need to understand. Angina is always
Like
present. And what I mean by that is they always have a clogged artery.
Chest pain.
But they can get enough blood flow through it unless they increase their heart rate. When the heart rate goes up, now there's not enough blood to go through that blockage. That pain is now temporary, but the blockage didn't go away. That makes sense? So let's say that I have 80% block. As long as my heart rate is 60 or 70, I can get enough blood flow through that 80% blocked coronary artery to where I'm not hypoxic. I go out and mow the yard. I eat a big old meal. I argue with the wife. Eating, exertion, emotion, those type of things will make that heart rate do what? Go up. And when the heart rate goes up, it needs more oxygen and sugar. And because that's blocked, I can't deliver enough blood flow. So that heart starts becoming hypoxic. We start building up that acid. They start having chest pain, shortness of breath. If they sit down, they rest, they relax, they get oxygen, they take nitro, their heart rate comes down. They don't need that much oxygen now. The pain will go away. So they have a history of coronary artery disease, also called arteriosclerosis or arthrosclerosis, hardening of arteries and buildup of fat and plaque in the arteries. They exert themselves, yell, emotion, eat, heart rate goes up, chest pain. They sit down, they rest, they relax, pain goes away. That's angina. Pain starts at rest for no reason, probably an MI. If they have a history of angina, so 56-year-old male mowing the yard, sudden onset chest pain, shortness of breath. He goes ahead, calls 911. He sits down on the stairs. Upon your arrival, he's pain-free. But he tells you, man, my chest has not hurt that bad in years. I had to take 2 nitro before it goes away. And most of the time, I take 1 nitro and I'm fine in 5 minutes. It still started with one of the E's. It still went away, but something was worse about it. It lasted longer or it hurt worse. That's what we call unstable angina. MI starts at rest, doesn't get better. Angina starts with one of the E's, goes away, and they've had that pain before. Unstable starts with one of the E's, but something about it was different. Hurt worse than normal, took more nitro than normal, lasted longer than normal. Something was different, but it still went away. Regardless of how the chest pain starts, if it doesn't get better at all, we're going to default to an MI. All right? What are your risk factors for an MI? You have modifiable and non-modifiable. Modifiable you can change with diet, exercise, or meds. Weight, cholesterol, diabetes, etc. Non-modifiable, your biggest one is your family. You can't change your parents. You can't change your age. You can't change your race. And you can't change your sex. Gender is not sex. We're not going there. All right? Biologically, you can't change your DNA related to cardiac history. So in the question, if it says something about their dad died at an early age, there's a good chance that person's going to have cardiac problems at an early age. A lot of times they will say, father died at an early age of an MI. Father had an MI at 42. 46-year-old male on the anniversary of his father's death, sudden onset chest pain, shortness of breath. He smokes 2 packs of cigarettes. His dad died at 42 from a heart attack. He's 46. Dad is 42. That's a huge risk factor. If he outlived his dad, that's bad. And what I mean by that is cardiac history. If the males in your family die in the 40s of heart attacks, your ass probably going to die in the 40s of heart attacks. You can't change that. You can't change that. It's the anniversary of his father's death. That's emotion. That's going to bring angina, right? So at the very least, he's having anginal pain, aka chest pain, possibly an MI. We'll do a 12 lead to try and figure out. Smoking is also a risk factor. So he has family history, emotion to bring it on, and then smokes, which is a modifiable risk factor. Yes.
It's Prinzmetal's angina, same thing as the regular.
Prinzmetal's
Yes.
angina. So Prinzmetal's angina is a vasoconstriction that comes and goes.
It's a spasm.
It's a spasm. All right? It's a spasm.
So it's not the angina we're talking about.
And the angina we're talking about is from a blockage that is always there,
Right.
that is going to be there until it gets so bad they go to the cath lab and they clear it or put a stent, which is basically a bypass around it.
So if you were to do a 12 lead at the time that somebody's having an angina, it
A
would
Prinzmetal? Or a regular
no,
angina?
just a regular angina. Would it show ST elevation?
Not necessarily.
No.
Not necessarily. And even an MI won't show ST elevation sometimes.
Okay.
Not necessarily.
You know this?
Not necessarily. Because what we have to understand as we look at our 12 leads is, and as you guys have figured out by now, I'm not an artist. All right? Right atrium. Shut up. Right ventricle, left atrium, left ventricle. Vena cava coming in. Pulmonary arteries to the lungs. Pulmonary veins carry it back. And I know the aorta comes out the back from the top, and I can't draw 3D. Alright? Toilet paper my ass are your valves. Tricuspid, pulmonic, mitral, and aorta. If I have my LAD and my left circumflex, alright, and the blockage is right here, that's the only area of the myocardium that's affected, that person will not have any 12 lead changes. If it was up here and everything below is affected, that's a widowmaker where it's blocking both left circumflex and left anterior descending. This person's probably going to have major ST changes. But way down here, downstream, you're probably not going to see anything. Up here, it depends on when you get there. If the person has chest pain, shortness of breath, and they call immediately, we may not see it because we get there too quick. The longer we're with them, we may see it occur. Yes.
Have you ever seen a widowmaker?
Yes.
They make it.
I have no idea. I doubt it, but I can tell you that I don't. Maybe 2-3 times in my entire career have I actually followed up to see if they made it out of the hospital. I get your butt to the hospital, I'm done. That's my job. My job is not to hold your hands and follow up. You make it, you make it. If not, I did my part.
It dies, it dies.
At the top is the left vein. Is that what you're saying?
The left interior into the left circumflex. Don't worry about this drawing.
Okay.
Don't worry. Don't. Just don't. I'm just
Saw your notes.
for illustration.
No more.
All right? For illustration purposes. And what I'm trying to say is the further downstream it is, the less of the muscle would be affected. The higher upstream, the more of the muscle. That's why some MIs have 12 lead changes, some don't. Some you won't see on a 12 lead because it's tucked around on the back. Some of them have vague symptoms. You can't rely just on a 12 lead. We treat the patient first, then the monitor. What does a 12 lead do for our treatment? It does two things. It lets us know if there's enough damage to activate the cath lab. Even then, it doesn't mean they're 100% having a full-blown heart attack. And it also lets us know whether or not they're going to be sensitive to nitro or not. If they're having chest pain, shortness of breath, cool pale diaphoretic, and the 12 lead is normal, you're still going to do what? No. If they're having chest pain, shortness of breath, cool pale clammy skin, and the lateral wall is where the MI's at, you're still going to do what? No. Just because the 12 lead is normal doesn't mean we're not going to treat their chest pain. All the 12 lead is doing is telling us, do they need to go straight to the cath lab or not, based on what we see, and will they be sensitive to nitro or not? That's all that 12 lead is telling us. They could have a perfectly normal 12 lead and be having one of the biggest heart attacks ever. It's just where it's hidden at. Or we got there so quick there is no 12 lead changes. Or they may start out with a perfectly normal 12 lead, and by the time you get to the hospital, they have massive ST elevation. Or you may get there and they have a little bit of ST depression. ST depression is ischemia and hypoxia. ST elevation is injury. 2 or more leads is considered a possible MI. A possible MI without a bundle branch and without LVH, we activate the cath lab. If we have LVH or a bundle branch, we'll fax it and we'll default. Because we don't know if that LVH is worse than normal. We don't know if that bundle branch is new or old. We don't know at this level whether that's new or old. So we still treat a modem and then we send the strip and let them decide, because those are false positives. All right? So those are things that the 12 lead may or may not tell us. So let's look at our 12 leads. All right? Down and dirty. I highly advise, once you have a couple of years on the department, to take a full-blown 8-hour 12 lead class. Don't do it before the registry. All right? Don't do it before the registry. Why? It's going to just blow your mind, and then you're going to get confused, and then you're going to believe that everybody's having an MI. All right? So just keep it simple for now. Don't overthink this. So we're going to keep this super simple. We look at a 12 lead. All right?
I think that's what I've been doing.
Uh-huh.
I've been confusing the shit out of my classmates too.
Uh-huh. All right. So let's just start real simple. 2-3 and AVF is what leads? What coronary artery?
RCA.
The right coronary artery. Okay? This is going to tell us when we look up, because it's basically shooting through here, it's going to look at the back of the left ventricle, but more importantly, it's going to look at that right coronary artery. When we look at that right coronary artery, that's going to help us determine whether or not that person's going to be sensitive to nitro or not. If I see elevation 2-3 and AVF, I'm going to take V4R right here and zoom in on that right ventricle. The reason why is this going to let me know whether that person can tolerate nitro or not. If you have a blood pressure of 120/80, theoretically that's basically 120 coming out, 80 coming in. What is the job of the right atrium and the right ventricle? To take the pressure that came back from the toes, all right, because I'm almost out of pressure, and to increase that pressure to force the blood into the lungs, to exchange oxygen and carbon dioxide and bring it back to the left atrium. That's that right side of the heart's job. To take the pressure that's left from the rest of the body, because the blood made the loop, and increase it. Well, if I have a right ventricle involvement, that right ventricle can't increase pressure like what the heart was designed to do. So I got to have enough pressure coming in to push past the damage, go to the lungs, and get back to that left atrium. That's why it's called preload dependent. The amount of preload coming in will determine if it's enough pressure to make it to the left side of the heart. Which is why if this person receives nitro, it could bottom their pressure out. Well, if it bottoms their pressure out, you start an IV, it comes up through the AC, through the subclavian, directly into the what? Vena cava, which goes directly into the right side of the heart. That's why it is best to do a 12 lead and have an IV prior to the administration of nitro. That's why it says use caution if you have an inferior wall MI. All right? Does that kind of make sense? This is more likely is going to need fluids than necessarily nitro. Not always, though, but more likely. So the registry is going to say, which of the following patients would you consider giving a fluid bolus to? An inferior wall MI, a lateral wall MI, a septal wall MI, or an interior wall?
Inferior.
Inferior. All right? That's my inferior leads. Now, V1, V2 is your septal. It's also where we're going to look at bundle branch blocks. And it's also your LAD, left anterior descending. Because V1, V2 is looking across the bundle of his, this is a good spot to look for bundle branch blocks. Remember in a bundle branch block, if I'm driving my car and I have to turn left to go down into the S wave, it's a left bundle branch block. If I'm driving my car and I got to turn right to follow the S wave, I have a right bundle branch block. Don't overcomplicate it. At your level right now, if we see a bundle branch block, it's going to make our 12 lead non-diagnostic. We're still going to own them. Consider oxygen, aspirin, nitro, morphine for the chest pain. We'll send the 12 lead and we'll let the hospital decide if they want to activate the cath lab or not. Don't worry about axis deviation and all that other stuff till you get your red patch and get a little bit of experience. Down the road, you will learn when you can actually start looking at those bundle branch blocks and see some other things. Yes?
So I get the basics on how to see them, but and this might seem like a dumb question, but, you know, all the reading I've done, I still don't really understand what a bundle branch block is.
All right. So let's do away with this. Right here at your junction, you have bundle of Kent and bundle of his. Electricity runs through. You basically have a right highway that carries electricity impulse to the right side of the heart, and you have a left highway that carries it to the left side of the heart. What ends up happening is instead of this voltage arriving simultaneously to the right and left ventricle, maybe there's traffic and a roadblock on that right side. So now what ends up happening is the impulses are delayed moving through the ventricle, which is why you would see a lot of times that bunny rabbit or notching at the top of the QRS. And obviously I'm not an artist, but that's all it is. It's just a conduction delay.
Okay.
You and your buddy get on 635 and you're going to meet wherever. He gets stuck in the right lane of traffic, you're in the left, you go past him, but you eventually end up in the same location. It's just a conduction delay.
Oh, so like on a regular heartbeat, there is technically two different R waves. Just one is behind the other one.
Well, they're moving together. They
Yeah.
should be synchronous.
So that's why you see two R waves in there.
That's why we got the notching,
Got it.
because it's conduction delay.
Can you draw, is that a right or a left bundle branch? Can you show where the pointer is? Okay.
If I go this way, God, I cannot draw today. So if I was to come this way, which way do you have to turn to follow it? That'd be a right. If I was this way, when I'm driving my car backwards, which way do I turn?
Left.
Well, that's all you're looking at, right? All you're looking is which way do I got to turn to follow the S wave? From when I go back from the T wave, which way do I got to turn the car? That's all we're looking at. I go from the T wave, where's my S? Go left. If I go back from the T wave, which way do I got to turn to follow it? That's all we're looking at. Don't overcomplicate. We'll pull some up, all right? We'll pull some overheads up, all right?
Are these bundle branch blocks, are they working similarly like
like type 1 or like first degree, second, third degree? Are they?
Not really.
They're not the same thing.
Theoretically, a left bundle branch may be worse than a right because it's dealing with the left ventricle. But even then, there's people that have left bundle branch blocks forever and no issues. It could be acute. We don't know without comparing it to a previous. The bottom line is you see a bundle branch and they have signs of a heart attack, treat the heart attack, send the strip, let the hospital decide. You run on somebody that's having emphysema and they have a bundle branch block and they have no chest pain, shortness of breath, treat their emphysema. You run on a 27-year-old athlete that has a bundle branch, may just be normal because of his body size. Why are we there?
You're only looking at V1 and V2 because I read that they like to look at V1 and V6.
So V1 is where we're going for y'all's level.
Okay.
All right. If you suspect a bundle branch block in a regular 2 lead, do a 12 lead and look at V1. All right. We don't want to get so convoluted right now that we get all the shit mixed up in our heads.
Okay. Yes, sir.
All right. There's all kinds of things you can do at a 12 lead. For now, you guys need to learn the bare minimum.
Yes, sir.
All right. The bare minimum. Meat and potatoes. You can't have dessert till you finish your meat and potatoes. All right. Because we could get into like -80 to 180 axis deviation. Exactly. Keep it simple till you get your red patch and get some time on the ambulance. Then go take a good 12-week class. But let's just get through the registry. All right. V3, V4 is your anterior leads. Also has your LAD. V5, V6 is your lateral. Also has your LAD. Also has your left circumflex. So does one in ABL. All right. Now, this lateral is looking at your left ventricle. The left ventricle, if it has issues, it's not going to be able to eject blood out that comes in. If blood comes into the heart and makes it to the left ventricle, but it can't go out, it's going to go backwards from the left ventricle into the left atrium through the pulmonary veins, and it's going to do what to your lungs? Fill them up. That's where you get pulmonary edema. That's left-sided heart failure. So which MI would be sensitive to giving them too much fluid?
Left-sided,
A lateral. Which side needs fluid?
right side.
Inferior. So you see how they could ask that question. Which of the following patients would you withhold a standard fluid bolus from? DKA, Lasix overdose, ST elevation in 2, 3, and ADF, or ST elevation in V5, V6.
5, 6.
5 and 6, the lateral, because that could put them into CHF. That's why they word some of those questions that way. That's why it is best to have a 12 lead in IV prior to administration of nitro. But remember, it's not a 100% have to.
If somebody's already been diagnosed with CHF, are you automatically still withholding fluids, or how does that work?
If their pressure's elevated, they need CPAP, nitro, morphine, Lasix. If their pressure's below 90, you can't do CPAP, you can't do nitro, you can't do morphine, you can't do Lasix. So we have to give them fluids and pressors to get the pressure above 90 to where I can turn around and put them on CPAP and nitro. So you start teeter-tottering, and that's where our critical care nurses and then make money, because they're sitting there teeter-tottering between hanging a dopamine, dobutamine, or Levophed drip and a nitro drip and trying to keep the pressure above 90 to keep them on the vent as well. And they're basically turning each one up and down.
So, V2, 3, and ABF, are those all the right,
Coronary artery.
and that's the only one we get fluid to, correct?
Correct.
So everything else would be nitro.
Correct. For our elementary purposes, yes.
So I have a quick question, because we're running where a woman with CHF, you can clear the rails, but her oxygen saturation was still good. Would you still put her on CPAP?
Yes.
Okay. I just wanted to make.
Try and blow that out of there.
Yeah, because I mean, she was still breathing good, so I wasn't certain.
Yeah.
We did.
And so here's what we need to look at with CHF real quick. I know we need a break. Is this fluid's going to back up from the left side in the lungs? All right? Oops, wrong color.
Wow.
So we have our bronchioles to our alveoli. All right. Normally, blood will go right ventricle through the pulmonary arteries. It moves this way, goes in the alveoli, exchanges oxygen and carbon dioxide, and then it's carried from the pulmonary veins to the left atrium. So basically, I go here, pulmonary arteries to the lungs, drop off the carbon dioxide, pick up oxygen, come back through the pulmonary veins to the left atrium, left ventricle, go out. When they develop left-sided heart failure, a lateral wall MI, left-sided heart failure, also means CHF, is now they start to flow blood backwards. So what ends up happening is the left ventricle sends blood backwards against the gradient. So now I have the right ventricle pumping blood into the lungs and it coming backwards from the left side. These end up meeting here in the alveoli and it forces the blood and plasma across the alveolar membrane into the lungs, and it ends up filling up their lungs with fluid. If they lay flat at night, it disposes across the upper and lower lobes, especially in the back. So they get what's called paroxysmal nocturnal dyspnea, or sudden onset shortness of breath at night. So they end up having to set more and more and more upright to leave the upper lobes open for oxygen exchange. Meanwhile, their lower lobes are full of fluid. That's why they become orthopnic and try and set more and more upright. The goal is to get this fluid pushed back into the bloodstream and get it ejected out to the rest of the body through the use of CPAP and nitro. The reason why nitro is the most effective drug is when they start backfilling into their lungs, their cardiac output goes down, aka the amount of blood going through their body. Besides the brain, what's the most sensitive organ in the body to volume and pressure changes? Kidneys. Which is why on top of the kidneys is what gland?
Adrenal.
The adrenal glands. So when the amount of fluid coming through the kidneys goes down because they're drowning themselves, the kidneys will detect that. They'll release epi. The alpha effects of epi will raise the blood pressure. The beta-1 effects will stimulate the SA node, and then the SA nodes start to beat faster. But where's the damage? So the SA node will start beating faster than the left ventricle, which is why most commonly CHF is in an AFib or a flutter. The beta-2 effects are going to dilate the bronchioles and the alveoli. Well, what does Pasquelli's law, the pipe law, tell us? When we make a container bigger, more fluid goes in it and pressure goes down. So I increase the amount of fluid coming into here, and because there's no back pressure on top of it, it makes it leak into the lungs easier, which is why I got to do CPAP to force it back down in there. However, to use the CPAP, they have to be alert, conscious, a tidal volume of at least how many centimeters of water? 5 to 10. Because they have to breathe deep enough to break that seal. And then they have to have a pressure of at least 90 to where when I push that fluid back into the bronchioles, I got enough pressure to move it onto the left ventricle and eject it out. Plus, when you put them on CPAP, it's going to put pressure on the vena cava, which is going to drop their preload as well. So I have to have that pressure above 90. If it's below 90, if you look at page 1, their cardiogenic shock, which is basically CHF, with the pressure below 90, we try a fluid challenge. Yeah, they're already drowning, but maybe an extra 200 fluid will get the pressure above 90 to where I can go ahead and put them on CPAP. If that doesn't work, then I'm looking at hanging dopamine or Levophed to get their pressure up. Every once in a while on the registry, they will throw a dobutamine drug at you. Dobutamine is basically the cousin of dopamine. It has alpha effects, it has dromotropic and inotropic effects, the contractility and velocity, but it doesn't have chronotropic, which is rate. The reason why it's a decent drip for CHF is because usually they're an AFib and the SA node's already firing quick. Dopamine can increase that SA node. Dobutamine, because it doesn't have the rate effects, is a little bit better drug in some systems for the CHF. Just remember, it is the cousin of dopamine, but doesn't go as fast. It's 2 to 20 mics per kilo per minute. It looks like dopamine. It's just not as fast. Everything else is the same. All right? So that is our left-sided heart failure. Our right-sided heart failure, on the other hand, if we're damaged here, that right ventricle is too weak to force fluid into the lungs. So the fluid comes in the vena cava, hits the right ventricle, backs up. It will cause JVD. Gravity will pull the fluid out, create abdominal ascites and pedal edema, but their lungs are clear. A lot of these patients will say they take a water pill, and you ask them if they have heart problems, and they tell you no, because they don't equate the fact that their right ventricle is weak. That's why their feet swell, but it's literally just gravity. Push it up, gravity takes over, pulls that excess fluid to their feet. That's why they're on that water pill, that Lasix. Right side, in order to push past the damage, we got to increase the fluid. The only way I can increase preload, start IV and give them a fluid bolus. That's why we have to look at that 2-3 AVF versus a lateral wall MI. Starting to make a little bit more sense?
A little bit.
Keep it simple for now. All right? Keep it simple. Do not overthink this stuff and don't go, well, what if one time at band camp, nobody in here is playing the flute? All right? Keep it simple for now. All right? 12 leads. We're going to keep it real simple. Inferior, 2-3 and AVF, right coronary artery. V1, V2, septal and bundle branches. LAD is everywhere but 2-3 and AVF. Interior, V3, V4, LAD. V5, V6, lateral. We add the left circumflex because 2/3 of your heart is your left ventricle. It needs 2/3 your coronary arteries. Easy enough? 1 in ADL, add your left circumflex. If I have ST elevation over here, the mirror image should be upside down. What's that called if it's inverted on the other side?
Reciprocal.
Reciprocal. If I have ST depression here and no ST elevation over here, what is that ST depression indicative of?
Ischemia.
Ischemia. It means this area of the heart's becoming hypoxic. If I have depression here but elevation here, this is the damage. This is a upside down view of it, a reciprocal change. ST elevation is injury, suspect infarct. ST depression is ischemia. Two or more continuous leads without an LVH, left ventricular hypertrophy, or a bundle branch, we need to activate the cath lab.
LVH is shown in 5 and 6, right?
A lot of times you could look in V1, 2, 3, and 4, and it will look like this. You'll see it, and you'll see that, where basically your QRS is touching the lead below. And I forget, I think if you add the QRSs, or the RS and V1, V2, it's 40 millimeters combined, isn't it?
35.
35?
Yeah. I mean,
To me, if they touch, good enough.
exactly.
I mean, if they're touching the lead below it, that's good enough for LVH. And the problem is it took so much time and energy to move through that left ventricle that a lot of times you'll see this, and it makes it look like you have ST elevation. That's why it's called a false positive. Same thing with the bundle branch. By the time it works its way through, it ends up making it looks like it has an elevated ST segment. I don't know if this is true elevated or not without comparing it to a previous 12 lead. For now. Okay? Get on the cardiac side. Come back in at 240. My throat's hurt.